Okay, I think we can start. Good morning, everybody. My name is Catherine. For those of you who don't know me, I'm the CEO of the Baird Institute. Thanks to everyone for joining us today. And of course, I'd particularly like to thank you all so much for your support. At our recent mid-year appeal back in June and July, we were trying to raise money for the next phase of our research into cutting-edge artery replacements. And I'm really happy to say that we surpassed our goal of 195,000, which is just amazing. And we can't thank you all enough. I'd just like to introduce you to a few of our team who are here today. Daria, who's our data research assistant, Lisa, our engagement manager, and then, of course, our presenters, Professor Paul Bannon, chair of the Baird Institute, and Dr. Robert Hume, lead of translational research at the Baird Institute. Rob is a research fellow at the University of Sydney and lead of translational research at the Baird Institute. He undertook his bachelor's and master's in biomaterial science and tissue engineering at the University of Sheffield, UK, and his PhD at the University of Cambridge in the UK, before moving to Australia to complete his postdoctoral training at the Westmead Institute for Medical Research. He now co-leads the Baird Institute's Centre for Heart Failure and Diseases of the Aorta in the university's famous Charles Perkins Centre, where he develops cardiovascular regeneration therapies, aiming to help patients regrow their damaged hearts and arteries. Paul is chair of the Baird Institute, a cardiothoracic surgeon of international standing, with clinical appointments at Royal Prince Alfred Hospital, Concord Hospital and Strathfield Private. At RPA, Professor Bannon is the co-chair of the Institute for Academic Surgery and director of the Robotic Training Institute. At the University of Sydney, he holds the professorial chair of cardiothoracic surgery and the Bosch chair of surgery. He is also the current head of the discipline of surgery for the Sydney Medical School and the academic director of the Translational Research Facility at the Charles Perkins Centre. In this webinar, Rob and Paul will share exciting updates from their research into next generation degradable artery replacements at our Centre for Heart Failure and Diseases of the Aorta. With your support, the team is advancing imaging studies and developing improved graft designs that bring real hope for better health outcomes. Paul will be giving a brief introduction to this vital research, and then Rob will present on their work and current findings. Both will be available for a Q&A at the end of the presentation. But just before I hand over to Paul and Rob, a little bit of housekeeping. All attendees' microphones have been muted just to be sure that the webinar goes smoothly. If you have any questions throughout the presentation, note them down and you will be given the opportunity to ask them at the presentation. Or you could use the Q&A button at the top of the webinar page to send a question through during the presentation, and we will get to all your questions at the end. So I think that's it. Over to you, Paul.
Thanks, Catherine. I'm just going to, and everybody for joining. I'm just going to get the sharing going on here. Just give me a second. Hopefully that's it. Okay. Thanks and welcome everybody. I'm going to be speaking just quickly as an introduction about some of the research and the aortic program, I guess, but really leading into the main event, which is, as always, Rob, which is the exciting bit. But a bit of background of everything else we do, I think, is always helpful because it also explains a little bit of how we got to where we are with Rob's work. So some of this may be a bit too simple for some of you, but I think it's always good to go over it. I'm struggling to get some image out of my way here, but here we go. The aorta and aortic disease. So, and just be a warning, there is a little bit of operative imaging a little bit further on, not much, and I can take it off quickly, but hopefully it doesn't upset anybody, but please let me know if it does. The aorta is obviously the largest blood vessel in the body, and it pumps blood directly from the heart to everywhere. So the branches are myriad, and it really tells you that if there's a problem with the aorta, that it causes a problem with every organ system in the body. Online, I've had experience with the devastating consequence of aortic dissection. And obviously, as it's the tube from which the pump delivers everything, is the primary source of oxygen nutrients for everything, not for many, for everything. Therefore, disease or injury that affects the blood flow through the aorta can be life-threatening, as we know. That's just the background. Why can't I? Okay, there we go. Yeah. Sorry, guys, just showing my age. So damage to the aorta, and it's important to remember the aorta is an elastic tube. It damages the aorta for whatever reason, causes it to become weak. And as high pressures, it's designed to last your lifetime. And if you think about it, 60 to 70 beats or more per minute forever, it's quite extraordinary that it doesn't fail more often. But there are some conditions in which it does fail, and those are primarily what we deal with are genetic conditions of, varying terms, varying names. But even without a known genetic condition, a family history of aortic aneurysms or dissection or split is critical, and it really highlights the need to look after these patients. Atherosclerosis or hardening of the arteries does occur in the older population, but not so much the younger ones. The younger people, we're talking about genetic conditions. Importantly, most aneurysms have no symptoms until they dissect or rupture and kill people, or hopefully get to hospital so we can deal with them. That middle picture there on the right is an aortic aneurysm. So you've got a normal aorta. It's also important to remember most normal aortas are only about 3 centimetres. And but an aortic aneurysm, usually we talk about 150% of that, so half a size again. And that only takes you up to about 45 millimetres or 4.5 centimetres. And it's of those sizes the aortas start to split. And that's just a picture of aortic dissection. And aortic dissection can either rupture and kill people immediately, or it can block the blood supply to various parts of the body. So that's the reason we need to deal with it. And this is, there's always certain patient experiences we've had that sort of define your practice. And this is a young fellow many years ago who had, as we turned out later, a condition called Lewis-Dietz syndrome, which is known as TGFBR, genetic variant. We didn't know that because it hadn't been described at the time. And he was only 28, and he split or dissected his descending aorta. That's the X-ray appearance on the left, the CAT scan, showing this area here. And in the end, we stented everything, and we replaced everything, we operated multiple times, and it really defined, he's alive and well, thankfully, with healthy children, but it really defined what we should do if we know about these things beforehand, and how we would deal with it differently. And as I keep saying to him, he's been a real learning experience for us all. So as a result, we developed an aortic program, and it covers the sort of procedures that we've learned to do or take on, and how. So in other words, what operations we do. We collect the data, which is the most detailed one in the country. Really important thing I'm going to touch on is we take from consenting patients biobank tissue for further research. That there's a lot of research that comes from that, but also the research widens, and we'll hear from Rob about that as well, some of that as well. And there's a multidisciplinary team meeting about all of these patients. And there's multiple different procedures that we do, but I think what we're going to focus on is the research and how do we sort of prevent it, I guess, or teach it better. So some of the procedures on the left hand, this is the operative stuff. This is where we preserve the patient's aortic valve and replace the aorta. So it's an aortic root reconstruction or David procedure, and that's so getting rid of the offending aorta using this Dacron tube, which is a sort of white thing I'm sewing the valve to there. And the images on the right are just the different complex ways we replace the arch of the aorta turning over in the neck down to the chest. But they all involve using that synthetic material, which is the best we've got, and it works to the largest degree, called Dacron. And we can do obviously some complex things with that. That imaging on the left there is where we've totally replaced the ascending aorta above the heart. You can see the valve in the bottom there, just working in here. And the whole arch has got a stent in there now, and the head and neck vessels are all coming through another Dacron tube all the way down here, allowing us to put the stent in. And this is what we call a frozen elephant trunk again with Dacron. So we can do all of these things, and for the most part it works. So why would we do anything differently? And so the synthetic materials, they last, they stretch a little bit over time, but anything synthetic can become infected, although it's only a low risk, but it can be devastating. So it's not totally resistant to infection, but also we think that there's a bit of evidence that suggests it upsets the flow or it doesn't have the sort of normal flow of, if you remember, that elastic aorta. So it might be causing pressure waves down the rest of the aortic tree that we think that may propagate further injury. And although we're not totally clear on that, it probably is best if we can produce something that has the same elastic characteristics as the aorta that we're born with, and that therefore would also be resistant to infection. So there's probably some good reasons to try to head down that path, which we'll hear from. But there's other research we do as well. We're keen to know why the aortas dilate and what the actual sort of coding or messaging is going wrong with the way the aorta responds to each blood pressure spike or each heartbeat. And there's quite a lot of work that we've done, Richmond, Jeremy, myself have done in the past, trying to outline what the mechanics of that is going on. And again, the biobank tissue is going to help us do some of that work as well. And I've stolen these slides from Cassandra Malecki, who's just fantastic, another postdoc working with Rob, who looks after the biobank for us as well, amongst many other things. And we collect, thanks to a lot of very generous patients trusting us with their own tissue. We do collect samples of the aneurysms that we remove, some of the heart muscle work, and that has allowed us to either do the research ourselves or make it available for other groups to do this research. We combined our work with our collections with the Sydney Heart Bank, overseen by Sean Lau. And you see there's massive, more than 16,000 samples there. So it really is a fantastic resource. And we do all sorts of things with that tissue in the bank. We take some fresh, we take some what we call RNA later preserved tissue and fixed in formalin as well. And that gives us each of those different ways of preserving the tissue gives us different things we can get out of that. And we've just actually been plotting a bit of a plan of what we do with some of that tissue just this morning. And we break down where these tissues have come from, what the conditions are in the background. But if you look down there, there's a group of FTAD. That's familial thoracic aortic aneurysm disease, in other words, non-syndromal. So these are patients that we don't know what they've got, yet they still have aortic aneurysms, and that number is growing and growing. So that's the bit that we really need to look at, as well as the bicuspid aortic valve group, to look at to get some information about what the risk of major catastrophe of these patients are, why the aneurysms develop, and how we can intervene a little earlier. And there's a few projects, I'm just listing these two, that Cassandra's been involved in, looking at testing potential therapeutics on the cells from the aortic tissue to see if we can improve that function that we know that is disordered. And also, importantly, she's just started this work a little while ago, understanding how the aorta changes as we age and how this can increase our risk of aortic disease and heart failure. So that's a sort of just a quick synopsis of some of the research or the surgery that we do, some of the research that we're doing, some of the research we're planning. But I really want to hand over now to Rob to talk about the main event. I'll finish there.
Thank you very much, Paul. Very much appreciate that introduction, and certainly makes my life a lot easier. I'm just going to share my slides.
I hope I've stopped sharing. Is that right? You're okay? Yeah.
Yeah, I think we're all
Thanks.
Good. Can we all see this? Is this okay?
Yep.
Yep. Brilliant. Okay. So I'm going to start just by kind of mentioning the centre and kind of the key players for this project here. And as I said, we're over at the Charles Perkins Centre, and the centre is very much a collaboration between the university and the RPA, and obviously the Baird Institute as well. And key people are obviously Paul, as well as Lakshay, who's an RA, and Wade, who's a PhD student working on this project, as well as Tim, who's another PhD student working on this project. And Tim is also a vascular surgeon as well. which makes things a lot easier when we're doing this kind of research. And there's a bunch of different collaborators that we do work with, but very key people that I really want to mention up front is Tony Weiss and ZU, who are really important collaborators. They're biomaterial science kind of tissue engineers, and they've worked with Paul in the past and really been the ones that have kind of pushed this work forward in terms of creating these new grafts that I'm going to talk about in a second. So a lot of this kind of was already covered, so I'll whiz through it a little quicker than I would normally, but essentially, you know, a lot of different reasons that your arteries can become damaged. You can have coronary artery disease, so a buildup of plaque in the coronary vessels for the heart. You can have peripheral artery disease, so buildup of plaque in the peripheral arteries, quite commonly in the femoral artery, and obviously these aortic aneurysms as well. And all these different genetic diseases, which Paul's mentioned already, so Marfan's, Ehlers-Danlos, Loeys-Dietz, bicuspid valves, and you know they can all lead to aneurysms, and most specifically in the aorta. But even just high blood pressure and trauma and accidents can also cause damage to your arteries. So what do we do? Well, Paul was talking about the synthetic alternatives, but you know, one alternative, at least for smaller vessels, you can't be doing it with the aorta because it's far too large, is these basically they're called autografts, where we take an artery from somewhere else in the body and use that to replace the damaged artery somewhere else. So you could take like the radial arteries or the great saphenous veins, and this is actually an autograft done by Tim over at the RPA. And obviously you can understand that these are not very highly available. You only have a certain number of them in your body that you can use, and they also cause damage at the donor site. So where they're harvested from in your leg or your arm or your internal mammary arteries, it's going to cause damage there and cause some morbidity at that site. So the synthetic alternatives that Paul was talking about before, we got Dacron, and in smaller vessels, you've also got ePTFE. And ePTFE is just the fancy name for Gore-Tex, essentially. And you know Gore-Tex from making rain jackets and drinks bottles. But you can also make these grafts out of ePTFE. And that's what's commonly used for the smaller diameter graft replacements. These are highly available. You know, you can make them at the kilometer and very cheaply. It's really no problem. And there's obviously no damage at the donor site because these things are synthetic. But as Paul said, they are very stiff. So they're much stiffer than your nice elastic arteries. And especially at the smaller diameters, they can actually become occluded and blocked as well. So, for instance, if you have to have a heart bypass, the only real way you can have a heart bypass is to use these autografts, so the vessels from somewhere else, because the PTFE grafts that they've tried in the past have been absolutely terrible. And they block up about 70% in 2 years. So if you're trying to bypass a blockage in one of your heart arteries, as you can see here, you don't want something that's going to become blocked itself. That would be a bit of a disaster. So what's the solution? Can we find something that's as elastic as the arteries that we can make, so it's highly available, something that doesn't cause damage because it's synthetic, so we can just make it, and one that doesn't become blocked, so it's highly patent, which means it's got low occlusion, which means it doesn't become blocked as much. And also, ideally, we'd love to put something in there that it basically encourages your blood vessel to regenerate and the graft is no longer needed. So that's what ZU and Tony have been doing for quite a few years. And they work on and have worked on, and so have I, worked on a protein for a long time called tropoelastin. And tropoelastin is like the highly elastic and degradable natural protein. So you have tropoelastin in the body. And it's actually very abundant in your artery walls, and it gives your skin its stretchiness, lungs stretchiness, and more importantly, your blood vessels, their kind of elasticity. And they also worked on another material called polyglycerol sebacate. And this is a polymer, so kind of like a plastic, that you can make in the lab. And essentially, as it degrades into glycerol and sebacic acid, which are just harmless metabolites that occur in your body anyway. So you can put this material in and slowly it degrades into naturally occurring metabolites. So you might be thinking, why do we want it to degrade? And I'll get to that in 1 second. So they made these really nice artery replacements. Here you can see one of those grafts. And this is using scanning electron microscopy. So you can see it at very, very, very high magnifications, and you can see the kind of structure of it inside. And then they performed some testing on these kind of small prototypes and found that the elasticity of these grafts, so TE-PGS in that bottom left corner, that's the graft name. So you'll see that the whole way through, TE-PGS. So that's just our novel grafts. And you can see that it has similar elasticity to the native artery. So the lower the number, the more elastic, and the higher the number, the stiffer. And you can appreciate as well that Gore-Tex, the ePTFE, the Gore-Tex, is way, way stiffer than the native artery. So then they put them into these small animals, and they put them into aorta. They used an aortic replacement model. And then over time, that aorta actually regenerated and formed a nice new aorta with organized cell types and structures all within it. And the graft essentially just degraded over time and was replaced with this nice new aorta. So this is all great, but if we want to go anywhere near clinical translation, then we have to upscale everything before moving into humans. So that's what we did. So we upscaled them and made them much larger than they were before. So they were only 0.7 mil in diameter, so very, very small kind of prototypes before. And now we made much larger ones, which is much more clinically relevant. And then Paul and Tim and Hugh actually implanted these into the carotid arteries alongside doing this lovely imaging that we did every 2 months using a CT scanner to do some angiograms, which you'll see in a second, as well as ultrasound to see the blood flow and how fast it was moving through and the diameter of these grafts over time as they degrade and remodel into hopefully a new artery. So that's what you can see here in terms of the angiograms. So on the left-hand side, on day 0 on the far left, this is just an angiogram of the carotid arteries as they are. And you can see the blood flows very nicely through them. This is before the actual graft has been put in place. And then we left them in their image every 2 months. And then after 8 months, you can see this image in the middle where our graft has still got blood flowing very nicely through it. Whilst the Gore-Tex graft on the left-hand side, sorry, I don't have a laser pointer here, you can see that artery became blocked and blood is really struggling to pass up through that artery, if at all. On the right-hand side of your screen, you can see that this is that quantified. So the sham across the top means that there was no graft put in place, and obviously they all stay patent, which means they all stay open with blood flowing through them. Whereas the PTFE, which is in yellow, you can see just after 2 months, 7 out of 8 of those grafts had completely failed in the fact that they were completely blocked and there was no blood flowing through them at all. Whereas our grafts, you can see the majority of them actually did stay patent. So that means they did stay open with blood flowing through them. And this is really a really big and very important, I'd say probably the most important result we've had so far, because this ePTFE was clinical grade ePTFE. So it's literally what would be used in the clinic for small diameter vessels, not for aortas. And we are massively outperforming those that clinical grade Gore-Tex, essentially, literally from the company Gore. And so what else did we find? Well, we knew that these things were going to degrade, and we hoped that they would degrade and remodel into a shape and a size that's more appropriate to the surrounding artery above and below it. So essentially, if you look on the left-hand side, just a reminder, TE-PGS is our grafts and ePTFE is the Gore-Tex grafts. And you can see we purposely undersized them at 4 millimeters into a 6 millimeter artery to see if it could degrade and remodel into a more appropriate shape and size. And you can see that's happened over time as you follow it down. These are images taken every 2 months. You can see that our graft is actually remodeling and resizing to a shape that's more appropriate to the surrounding native artery. Whereas the EPTFE, not only is it stay at 4 millimeter because it can't remodel because it's just a plastic, essentially, a woven plastic. You can see it's actually slightly narrowing as you go down, and there's actually an ingrowth of cells into that, which is not good. So the graph in the middle just shows exactly what we're seeing on the images on the left. So the graph in the middle, you can see that our graft, the purple line, starts at around 4 millimeters and then remodels to a size that's more appropriate and closer to that sham, so the native artery is closer to the native artery over time. And we've also got these really nice 3D angiograms, which were done at the very end of the study, which we're currently analyzing at the moment. Another thing that we did is using the ultrasound that I was talking about before. You can actually measure the blood flow, so how fast the blood is actually moving through the graft. And one thing that we found is that essentially if you have an overly fast blood flow, that's something called a stenosis, and it means it's speeding up a bit too much when it goes through a certain area. And what you can see is that after the surgery, all of our groups, so this is if you look at the graph on the right hand side, all of them go up straight away. And that's because we're cutting the artery and we're sewing it back together. And that creates like a little pinch where we've sewn it back together, which eventually relaxes and goes away. So that's that stenosis, that increased blood flow rate that you can see at the start of the graph. With the sham in the light blue, you can see that returning back to baseline levels. And our graphs have done a similar thing over time. Despite being 4 millimeters, you can see not only does it relax early on, but then it starts to remodel and come back down to that baseline stenosis rate or speed of blood flow starts to return to normal. Whereas the EPTFE, that's the Gore-Tex, the yellow line, you can see it's not good at all, and it really speeds up that blood flow to more dangerous levels that you really wouldn't want to see. So apologies for the gruesome picture, but for me this is very, very exciting, and this is what you can see in terms of how the graft has remodeled over time. So this is the graft on the top, is straight after we've sewn it in place on day 0, and you can see it's much smaller than the surrounding artery. Whereas after 8 months on the bottom of your screen, you can see it's integrated really nicely with that native artery on either side of it, which is really, really lovely to see. Okay, I didn't realize this had sound, so apologies for that. But this is some work that Wade did with Yelena Runjak-Kovacina over at UNSW and a couple of people from the Charles Perkins Center. And essentially what this is this is a mechanical test. So we can actually see, we keep saying that we're trying to make these elastic, nice elastic kind of grafts, but are they actually as elastic as we'd hoped? And essentially what it does is it pulls on your tissue until it eventually snaps. This is a slow motion picture because it's actually very fast, that sudden kind of snapping. But the force on this graph, so on the y-axis that you're looking at, that's how much pressure the device is putting on the material. And then the elongation is how much does it stretch. And so if you have a small amount of force and a large amount of elongation, which you can see in the our graphs, TE-PGS, and this other material, PCL, you can see a very small amount of force is needed to elongate it a lot, which means it's very elastic. Whereas the Gore-Tex, you can see a large amount of force is needed to elongate it, which means it's very, very stiff. So it's kind of just saying what we said before, these new graphs are as elastic or more close to the elasticity of the native artery, which is really great. This is that in kind of graphical form. And on the left-hand side, this is before we implanted these grafts. So you can see we've done tensile testing, so the stretch test. And you can see that our grafts are more elastic. So a lower number means it's more elastic, a higher number means it's stiffer. You can see our grafts are nice and elastic and have more elasticity compared to Gore-Tex. Now, after implantation, this gets even better, actually. So after 8 months of being in the carotid artery, and it's degrading and remodeling and changing, you can see that our grafts, which is the purple that you can see, are closer to the numbers that you can see for the sham. So the sham is basically native artery, no graft put in there, and our grafts are almost, or pretty much the same elasticity as that native artery, which is a really exciting result. Whilst, as you'd expect, that Gore-Tex is stiff when you put it in and it's stiff when you take it out. So that's kind of like the main exciting data points that we have so far. And next, I'm just going to show you some very preliminary data that's not finished yet, but it's kind of in progress, but I thought it'd be quite exciting to show you. So the first thing is that we're working with someone called Xinying Liu, and she is a computer modeling scientist. And she works on these very complicated models that are called fluid structure interaction modeling. And in simple terms, what it does is it actually incorporates into the model the blood flow, as well as the mechanical properties of your materials and how that blood flow will actually interact with those mechanical properties and the wall. So if you had a really elastic material, your blood would hit it and it would cause it to extend and push back, and then that would create another force back onto your blood. And this modeling is pretty much the only way that we can get these sorts of data points out of it. And this is kind of a little model just showing if we had that 4mm diameter graft in the middle with the larger diameter on either side, what that would do to all these different mechanical kind of engineering measurements. This is very, very complex in terms of how it's actually modeled. And this took about, I think it was about a week on like a supercomputer just to model like 1 or 2 seconds worth of blood flow. So really, really high powered, really exciting sort of data that they can actually produce this way. Another thing is just some preliminary images from the histology. So this means where we've got the artery, we've cut it up, and then we've cut it into really, really small little slices. And then we've stained it with these different stains to see where the cells are and where the different structures are. You see on the left, you've got the sham. So this is the native artery, what it normally looks like in a section. And then you've got the EPTFE, that Gore-Tex in the middle. And what you can appreciate from the Gore-Tex is that gray bit is where the graft was actually put in. And you can really appreciate that obviously it's not degraded, it's not changed in its shape or size. But the inside of that graft, you can actually see there's like a kind of ingrowth of purple cell. That's basically cells and tissue that's being deposited on the inside of the graft, which is not good because that means it's actually narrowing, and it'll be narrowing further and further. And I believe this is the only graft that didn't completely block. This is the only one that stayed open. And I believe if we left it going for a lot longer, then that would have completely narrowed and completely blocked as well. So I think we would have ended up with 0 if we could have carried on further than 8 months. And you can see our grafts, the TEPGS on the right-hand side, those little holes that you can see is where the sutures were keeping it in place. You can see that it's much more dilated. It's got like it's got a lot more space inside it to allow blood flow through it, which is why the blood flow was improved in our grafts. And you can see that it's got a more similar shape and size to the actual native artery. So this has actually undergone degradation and remodeling over those 8 months. And I'm pretty sure it had quite a while to go. We thought 8 months would be enough because that's what our previous study showed, and we did another 8 months here, but it looks like it's actually these larger grafts seem to take a little bit longer to degrade and change. And then lastly, I'm just going to touch upon something called COMET, which is really exciting that Wade's been working on as well. And essentially it's a way of us getting our tissue sections, putting on antibodies that have fluorescence to them, so you can see where those fluorescent, you can see where the proteins are by their fluorescence, and then imaging it and then removing the antibodies and then staining it again with some more antibodies, imaging it, removing the antibodies, and over and over and over to get us multiple antibodies all on the same piece of tissue, and we can put all these different markers all at the same time. So in short, it allows us to see multiple different cell types all at the same time. And this is just a little example. This is very preliminary data at the moment. We've only done one test run of this. This is just a positive control of sheep spleen. And you can see these different colors that are here to represent different cell types. So you've got T cells, which is a type of immune cell in this kind of yellowy color. You've got collagen in an orangey color. You've got fibroblasts, which are these collagen producing cells in this other color here, and macrophages in purple as well. So really, this is just the tip of the iceberg. We think that we should be able to get 20 to 40 different markers all on the same piece of tissue, and then we'll be able to really understand, as our grafts degrade and remodel, what's the immune response and what are the immune cells doing, and what's the full outlook of the actual structure inside it, and in how it's remodeling. And this is just a little snapshot of just one quick test run that we did on our grafts after 8 months. And you can see there's some collagen being deposited in there. There's a few macrophages in there. And we've actually got these different kind of layers going on in terms of the tissue that's in there. So very, very exciting, very preliminary. Yeah, we're very excited by where this is going to go. So essentially, we've shown that our grafts are nice and elastic. We've shown that we can synthesize them, obviously. They don't require any donor tissue. And they have this really high patency, which is really, really exciting. And, you know, this field of research has been stuck in this area for so long. And, you know, Dacron and EPTFE were made so long ago. And, you know, the fact that we can possibly improve them is really, really exciting. And obviously these grafts do encourage this vessel regeneration as well. So we've got reduced blockages, we've got this remodeling to approximately the size of the adjacent artery, we've got this improved blood flow in terms of the speed that it goes through, and we've got this similar elasticity when we do the mechanical testing to the actual adjacent artery around it. Now, we have found some of these grafts are undergoing like a slight dilation, so they're remodeling, and then just going a little bit too far. And in order to address this, we're actually making new graft iterations at the moment, which are currently going to be tested quite soon, where we want to completely stop any of that dilation from happening. So yeah, that's really exciting as well. And we want to cross all the T's and dot all the I's before we go anywhere near full translation into humans. So we want to make sure that's, even though we're massively outperforming EPTFE, we want to make sure it's even safer than safe. So yeah, just want to acknowledge many people, loads of people involved in this, and all the people at the RPA, all the people at the CPC, the Charles Perkins Centre, all the people in the hybrid theatre, and all the collaborators that are really essential to make this happen. And very importantly, thank you to you, because without donors, we wouldn't be able to do any of this work at all. And I really want to say thank you to you, because yes, it wouldn't be possible otherwise. So thank you. Thank you very much.
Excellent. Thanks so much, Rob. Really fascinating stuff. I'm sure you've all enjoyed that today, but I'm just wondering, are there any questions? We haven't had any sent through, but if you didn't want to type it out, you could just raise your hand. There's a little hand symbol at the top which says raise. You could put your hand up and then I can unmute you, and you could ask your question if you'd like. There's Mark Baird. This is actually Doug Baird's son. So he's got a question. Let me just unmute you, Mark. Have you unmuted him, Daria?
Yeah, I have. He can
okay.
Unmute and ask if you.
So, Mark, you can speak if you like. I can't hear you, Mark. Hold on a minute. Your microphone. See your microphone at the bottom is. Yeah, there you go.
Yep. Yeah. So I imagine
Hello.
it must be quite. Hi, everyone. Yeah, I imagine it must be quite a challenge to get the graft. You know, because if it grew the wrong shape, or if the original plastic that you put in there didn't decay in the right way, you mightn't get the result you want. So what do you need to, what can you do to improve the shape that it ends up growing?
Yeah, So we've got a couple of strategies, and one of the main strategies is to essentially we have the inside that's made out of tropoelastin polyglycerol sebacate. So they're the nice degradable materials, and we want to put on the outside a degradable material, but it degrades a lot slower, and it's a lot stronger. Okay. So that will allow the inside to have its elasticity still, whilst we kind of got this shell that it's almost sitting in. To kind of give it more mechanical strength so that it can remodel for longer and hopefully become a more structurally sound artery that's formed before the rest of it's degraded, essentially. So that's kind of like one of the plans. And the other of the plans is to make that woven shell in different ways. So the way that we make this at the moment is we use something called electrospinning. So it's essentially like a needle and a collector, and the collector's charged, and it slowly squirts out the proteins onto that collector, and it's kind of attracted onto it, and then it gets wrapped around a mandrel, so then you've got a nice cylinder that you've got out of it. And there's different ways that you can do that. So electrospinning is that kind of injection thing with a charge on it. But there's also this new thing called like electrowriting, which is really exciting, where it's much thicker, larger, kind of almost like threads of it around the outside. So that'll give it even more structural integrity for longer and allow it to remodel more appropriately, hopefully.
Right. Okay. Thanks.
Thank you.
Very good. Anybody else that has a question to ask? Now, I've got a question. Rob, when do you think this might be ready to be used in, in surgery? I know it's probably a long time away. I know research takes a long time, but I think people probably like to know that.
It's a good question, and unfortunately, it's kind of like how long's a piece of string. So basically, I don't know is the answer. And as I said, we really want to address this dilation thing completely and fully before anything like that. So these new kind of grafts that we're working on, we will be testing them over the next year or two, and then we'll be expanding them up to make them larger again and testing them again. So we've got a few years, I think, quite a few years of testing just to make our prototype absolutely beautiful and absolutely perfect. And then it would be a case of if you wanted to do translation, it's a long and rocky road with trying to find investors and trying to push it that way, and actually doing the trials and going through all the regulations. So quite a few years yet, really. To our advantage, we work with Tony Weiss, as I mentioned before, and he's the tropoelastin guy, and he's actually got a company that makes tropoelastin, and that's a $200 million company or something crazy like that. And so they have a lot of experience with this translation, and that would certainly make it faster. But there's no real answer I can give. Apologies for that. Mm-hmm. Yeah, hopefully within the next 5 to 10 years, but I think it would probably be more towards the 10-year mark. There's so much testing that has to happen, and phase 1, 2, 3 clinical trials are long and extensive, and for good reason, to protect the patients, to make sure everything is incredibly safe before it goes anywhere near a human.
Mm-hmm. And also, I think good to you pointed out during your talk the students, the PhD students that are involved, and this is obviously again from the support from our donors that allows these people to be offered scholarships. So we've got 2 at the moment that are actually receiving scholarships from us, with the potential for another 2 in the next sort of 6 months happening. So that's I was glad you pointed that out for people too. Any other questions? Oh, sorry, you go, Rob.
I was just going to say, first of all, thank you everyone for that. Much appreciated. And not only does it help those students with, just their finances, just surviving in Sydney, because it's not a cheap place to be, but it also helps us attract the best students as well, because if you have these scholarships attached, then it's much more competitive, and you can find much higher quality of students and PhD students.
Mm-hmm. Anyone else got a question? Doesn't look anymore. I mean, you can always send through questions afterwards if you didn't want to ask them now, or they came up later. And we'll also, obviously, we're recording the event so that anyone who was registered, we had 50 people register for the event, which is the highest we've ever had, which is great. And realising the middle of the day on a weekday is a bit hard for people to get there. So anyone registered gets a recording. Even if they didn't register, I can always send a recording out to people as well. So you can go through this in your own time, because I know it's a little complex, even though Rob doesn't make it seem very simple. Or explains it in a simple way anyway for us non-medical people to understand. So you can go through that in your own time and pause and record and rewind and listen again when you need to. So we should have that out by the end of the week. But if we haven't got any more questions, Paul, did you have anything you wanted to say at the end?
Yes, just to thank Rob and of course everybody else that works in the background there. I think the key point for me is that getting to the point where we can create a blood vessel helps us to understand not only the biomaterials and materials required to keep blood flowing through that vessel, but the biomechanics of that vessel. The end point might seem during that they were trying to build a vessel, but it's also trying to understand why the vessel fails in doing that. And so all that testing that we do of that replaced vessel and different failure rates gives us information as to why perhaps the native vessel might fail. Hence my preamble about aortic disease. So, the connection is always, sometimes it may not seem clear in other people's heads, but it's always clear in mine. And that if you're building something, you'll learn a lot. Even if you don't get to that end point, you'll learn a lot along the way. And I'm really interested to see that 4D MRI, or that predictive flow, that what you call those fluid dynamics through the vessels, because there's been a lot of emphasis what we call shear stress and flow patterns. We're not really sure what that means, but we do know that flow is important to blood vessels, the lining of the blood vessels, and it's that comment or that demonstration, the results of that remodeling with the flows is critical. When you have more, we know that we've got more normal flow, it'll probably remodel the way we want it to remodel, the way the body wants it to remodel, and will probably maintain the biomechanics. So that's just an example of what we learn along the way when we're trying to do this. So I learn something every time the team speaks about it. But I think it's tremendous work. Actually, I'm very, very quite excited about it. Also excited to hear Tony's company's worth $200 million. Presumably some of that money can come back to support the research. I'll be giving Tony a call very soon.
Okay, so just check finally any other questions. Doesn't seem so, but thank you so much for all coming along today and for your support. I know we've thanked you a lot today, but of course we wouldn't be here without you all. So we really do appreciate it, and also your interest in where your money is being spent. But have a great day, everybody. And as I said, a recording of the event will come by the end of the week.
Thanks, Catherine.
See you later.
Great
Thank you.
Thank
Bye-bye. Bye.
Thanks, everyone.